Welcome to Forensic Friday.
Where we examine the intersection of true crime, psychology, and the heart of being human in the middle of it all.
Oh, hey, bestie.
Hey, bestie. So this is going to be a mini where we talk about cluster A. So you know how we've been, hearing from people about Slender Man.
Yes.
It's so creepy. What does it mean that people are schizophrenic, doing these kinds of things?
My sister-in-law, Brittany, I have a lot of sister-in-laws. I have
You
three.
do. You have so many, and I'm still jealous.
I know I call them all my sisters, but
I know.
I have four sisters. Yeah, anyway. So Brittany was like, okay, who the F was Slender Man? And I was like, girl, he was made up.
Made up.
So I just wanted to make sure that we said that because I'm guessing she's not the only one who was someone like pretending to be this creepy dude in the woods,
No, Slender Man, if you think back, remember
Mhm,
creepy pasta?
mhm,
Slender Man was a fictional
mhm,
character that the internet collectively made.
mhm,
What happened is Slender Man merged with one of the girls' psychosis, one of the hallucinations that she had was
mhm,
somewhat similar to Slender Man. And my theory is she and her friend got obsessed with Slender Man, watched all the videos. This gal had a vulnerable brain, sees this image. This image looks like this hallucination she's already having, and they really started to merge. And we had a listener send me a message about, Anissa,
Yes.
right? So you and I kind of suspected and talked about the fact that in this three girl friendship on the Slender Man episode,
Mhm.
there was some mean girl stuff happening because that's what happens when you have three girls together trying to be friends. It just never goes.
Right.
So this listener sent me even more information about how Anissa was pretty complicit in everything that happened, and it actually supported our theory that Anissa was actually kind of trying to mistreat Bella in many
Right.
ways and exclude Bella. So, but that's the story with it. So,
Yes.
what we're gonna what we're gonna cover today for everybody is what in the heck does that even mean?
Perfect.
Yes, because it is confusing and schizophrenia is just a massive topic. And then
Mhm.
in the DSM, so many times I feel like we don't have names for things and the DSM does its best, right? But there's like whole gaps between disorders and differential diagnosis gets tricky and whatever.
When they change, they've changed
Yeah,
a few times and
they change things. So with schizophrenia, there's like so many words. Like there's a lot of different pockets with schizophrenia type behavior. And so we're going to break that down a little bit today. So I don't know that this will be our most interesting episode ever, but I find this stuff pretty fascinating. And there are a lot of people with these disorders, a lot of
right.
people.
Right. Well, and here's the thing. I'm going to challenge that it's not going to be our quote unquote our most interesting episode. It's not on a crime.
Hmm.
However, a lot of the crimes we have talked about and will continue to talk about involve these mental health disorders.
Yes.
And so I would encourage all of our listeners to still tune into this stuff. This stuff is like actually where the meat comes from, the
Yes.
understanding of these crimes, right? That's what, I mean, not to like toot our own horn, but I'm going to. That's what makes us a little different
Yeah.
from the other crime podcasts is we are literally forensic therapists.
Yes.
We specialize in forensic work.
Went to school for a long time.
School for a long time, have done a ton of trainings. And so we are trained to talk about this stuff. We are credentialed to talk about this stuff in this way. And so I'd encourage our listeners to still tune in because this is the interesting juice.
Oh, it is. It's juicy for sure. And also from a prevention perspective,
Yeah.
we are really ignorant as a society about major mental health.
Mm-hmm.
the significant disorders, we don't know nearly enough about this, and so we make assumptions that many times aren't true.
Mm-hmm.
And so we're going to try to tackle some of that today.
Yep.
So, with the personality disorders, the DSM organizes the personality disorders into clusters. So you have cluster A, which is what we're going to be talking about today, odd and bizarre thoughts and behaviors. And the personality disorders that fit in this is schizoid personality disorder, schizotypal personality disorder, paranoid personality disorder. Those are the ones we're going to be talking about. Those three
Mm-hmm.
fit under this header.
Yes.
Cluster B, we've already covered. That's your narcissistic, borderline, histrionic, antisocial.
Yep.
And the descriptor of that cluster is dramatic, emotional, or erratic.
Mm-hmm.
And then Nat is going to cover next time
Cluster C.
cluster C, which is avoidant OCPD, so obsessive compulsive personality disorder, which is different than OCD, even though
Yep.
there's overlap,
Yep.
and dependent anxious personality disorder. The key with that is those folks are anxious and fearful.
Mm-hmm.
So we're going to get to that. Okay, so I wanted to tell a story first.
Okay.
Okay.
I love story time.
So when I was running my substance abuse group, and this is the group, this was years and years and years ago. I'm not violating anybody's confidentiality.
Yep.
Because I also ran substance abuse group for years. And we've had a couple pretty spicy groups. We've had groups where somebody leaves behind a little meth, or maybe somebody tries to break back in after a group, or it can get spicy at times.
We've had TV stolen.
Yes, absolutely. So one night I'm in group, and it's one of my favorite substance abuse groups ever. It
Okay.
was a 2-hour group back in the old Alton Way office that Nat and I worked in long time
Mm-hmm.
ago. Worked there for years and years. And so somebody came in for group, and they were so kind and just really, really nice, but seemed a little bit distracted. And
Okay.
that always perks my ears up a little bit.
Yeah.
They were functioning normally, had gone through the eval normally with someone else, and they were just showing up for group. And also, again, it's a substance abuse group. So sometimes folks who are in withdrawal, or,
Yeah.
they're in long-term recovery, it just takes a minute for,
Yeah.
their brain to heal and for them to feel comfortable in these kind of situations. So anyway, comes in, has a seat, sits next to one of my all-time favorite clients.
Mm-hmm.
And the client, this person who I really trusted in the group, they were a real leader in the group,
Okay.
keeps kind of looking at this person, just keeps kind of looking at him, and is
Hmm.
kind of assessing. And I'm like, well, what? Something's going on. You know what it's like when you're running a group and you're like, something's going on.
Yes. Yes.
I don't know exactly what it is, but something's going on, and a couple people know it, and I don't know it yet, right?
Right.
Okay, so I have this new person introduce themselves,
Okay.
and this kind of OG group member looks at this person and says, "You got something else going on in your head, huh? Like you got something's going on."
What?
And he goes, "Yeah, I have schizophrenia." And the OG client was super nice and goes, "Oh yeah, man, I know a lot about that. I saw that a lot in jail." Blah blah blah. It was
Aw.
very, very nice, right? And so the I expected the client who came in to feel, I don't know, maybe welcomed by this OG group member, but he got really quiet.
Hmm.
So then I'm like, oh, maybe he's embarrassed. I hope he's not embarrassed, whatever. So then my favorite client looks at this other client and goes, "It's okay, man. Everybody with schizophrenia doesn't like me." And I was like,
Weird.
what is happening?
Yeah.
What is happening in this dynamic? Like, do they know each other from jail? Like, what is going
Right.
on?
Like, are you just like low key saying like, "Hey man,
Yes.
I know you," but not trying to name it?
Yes. I was like,
Yeah.
something is going on. And the client that I really can depend on, who's a really kind person, he just looked at him and said, "It's just something about me. I don't know if it's my face or whatever. But
Okay.
every time I'm in jail, I tend to set people off who have schizophrenia. And I want to make you feel comfortable. Maybe I could move over a little bit or whatever." And the person with schizophrenia starts laughing and said, yeah, I just really didn't like you for some reason, like right away, but you're really nice.
Oh.
So there was this whole like thing happening. So this person ended up being a wonderful and amazing group member. Like really did such a good job.
Yes.
What ended up happening is the two of them were laughing about this dynamic that sometimes happens in jail.
Okay.
And it was something about that man's face.
Interesting.
And I'm not going to go into details, but they had
Sure.
a very distinct face. And so I could kind of see it once they were talking about it.
Okay.
So, anyway, this client who had schizophrenia did wonderful in group. I mean, really was a wonderful group member. Did
Yeah.
great. And I've had many over the years. We have folks now that work with who have a little bit of psychosis or paranoia, and we
Yeah.
also see them in group. Now, for the most part, you really have to assess if the group is a safe and comfortable place for somebody with
Right.
schizophrenia, because, like we've talked about before, their brains are loud. There's a
Yeah.
lot happening. And so when you throw another 10 people and their experiences and their voices in, it can get overwhelming.
Right. And a lot of the times those groups aren't, especially the substance abuse groups, they're not quiet groups.
They're not quiet. They're wonderful groups, but they are not quiet and they can be
Yeah.
a little overwhelming.
Yeah.
So I'm curious for you, Nat, how have you seen this show up in group? And what's the difference between somebody who does well in a group or maybe doesn't do so well in a group if they have the same diagnosis? Like what helps them?
Well, I think first, I say this almost about everything is awareness that you have a diagnosis, right? So getting a diagnosis and being able to wrap your mind around it, because I've worked with individuals who are either are diagnosed and don't believe it, are diagnosed and won't tell us, or are not diagnosed, right?
And that makes it harder.
And it makes it way harder because we can't name the thing. It's harder for the group members to understand what's going on,
Hmm.
not just like say they have such weird behavior,
Yes.
and I think so when it's not known or when it's
Hmm.
not diagnosed or shared,
Hmm.
it makes it really hard not only on that individual, right? And they're the main focus, to be honest.
Yeah.
It makes it hard on their treatment team and people around them.
Yes. And the thing that's interesting about that is it's kind of a double-edged sword because we're saying it's so helpful to
Hmm.
know. But the same reason we want to know is one of the reasons that people try to keep it a secret. Is
Hmm.
they're so afraid of the label and the stigma and all that kind of stuff.
Yeah.
The other kind of little story time moment I want
Okay.
to tell before I get into the specific diagnostic stuff.
Okay.
I have an uncle with special needs.
Hmm.
We don't know exactly what those needs are fully
Right.
because back in the day, he's like 75, right? Back
Hmm.
in the day, if there was something different about you, you were institutionalized.
Right.
And so, what my grandparents did, which is has made things hard, but also was really compassionate and was them being an advocate back
Yeah.
then,
Yeah.
was they hid and compensated for the behaviors as long as they possibly could.
Yeah.
Right. And people don't do that as much now. And I'm thankful for that. But I really can understand
Yeah.
why people do that because you're trying to protect your person.
Yep. And especially back then. And I'm not saying this was your family,
Mm-mm.
but there's a big stigma around like what's happens behind closed doors stays behind closed doors.
Yes.
And so there was a big stigma around mental health and depression and
Yes.
people not wanting their family members to be seen as like, and I won't use any of the words that they used to use, but as anything
Yes.
that would tarnish the family.
You have to be quote unquote normal.
Yeah.
And with schizophrenia, there's a huge genetic component to schizophrenia. And so I can imagine in families too, if one person is schizophrenic and really struggles and maybe didn't get the treatment they needed, the next generation that may or may not have someone who's schizophrenic, they're going to handle it based on how the prior generation handled it. Like
Yeah.
there's a generational effect to this as well.
Yeah.
So when we're talking about this today, I really, really, really want us to be compassionate
Yeah.
and really look at this through the lens of what would I want my life to look like
Yeah.
if my brain did this thing, because I think that helps us have a lot of compassion. That's empathy,
Yeah.
right? Okay, so we're going to break it down a little bit.
Okay.
So with schizophrenia, there are a couple different things to look at. The
Hmm.
two personality disorders that are associated with schizophrenia like symptoms
Yep.
are schizoid personality disorder and schizotypal personality disorder. And there's a couple differences between them. There's a lot of similarities and a few
Yep.
key differences.
A
So
lot of people get these confused.
they get them confused, and it's
Yep.
really important to know the difference.
Yep.
Okay. Schizoid personality disorder is where we're going to start.
Okay.
The symptoms of schizoid personality disorder are the following: a pattern of disconnection from social relationships and a limited emotional range marked by having little interest in relationships or sexual experiences, choosing to be alone, no engagement in pleasurable activities,
Hmm.
lacking close friends other than family members, feeling indifference to praise or criticism, and refraining from displaying warmth or love.
Mm.
People with schizoid personality disorder will appear to be loners. They may gain more pleasure from math, computers, and electronics than
Hmm.
from people.
Hmm.
And according to the American Psychological Association in the DSM-5, schizoid personality disorder is an uncommon diagnosis in treatment centers, mostly because people with the condition often do not see it as a problem.
Hmm.
So during COVID, they talked a bit about like the happy hypoxic. Do you remember that?
Yeah. Yep.
What they were saying is people could have really low oxygen levels and they weren't feeling the impact of it fully. And so they're
Right.
sitting there with a really scary oxygen level, but they're functioning kind of okay.
Yep.
Think of schizoid as like a happy schizophrenia. I don't happy, I don't know how happy they are, but
Right.
they're
Right.
not really phased that they're wired differently, and they don't really want people to come in and have an influence on that.
Right.
Analyzing schizoid personality disorder statistics can be difficult due to the small incidence of this in the population. And it's, I mean, they say like it's really less than 1%.
Mm.
It's also a diagnosis people don't seek treatment for very often.
Right.
So little is known about the patterns and commonalities of people with this because we just don't see it a ton.
Yeah.
When the same risk factors happen in women as in men, women are more likely to develop a cluster B personality disorder, which
Mm.
is a cluster characterized by being overly dramatic and emotional.
Hmm.
Men are more likely to get an A or C cluster diagnosis because it is socially not as acceptable to be more dramatic and emotional.
Right.
So this is one of those chicken or the eggs things that you and I talk about, because it's like, are there really less women who are A and C, or are we just more likely to diagnose cluster B? What's
Right.
the impact of socialization on that? I think women are great maskers. I think
Yeah.
women know how to mask a lot of things,
Yep.
ADHD,
Yep.
psychosis, all that kind of stuff, right?
Yep.
Schizoid, we don't see in treatment except teens. So the
Hmm.
only schizoid clients I've seen have been teenagers. Why do you think that is? Teens, young adults who have this personality style.
I'm not totally sure. My first guess was like social isolation,
Yeah, social isolation.
like feeling weird in their own body and
Mm-hmm.
skin.
Mm-hmm.
Yeah.
But I would say even then, a schizoid person is not going to be super affected by that, but their
Sure.
family worries. So if you're
Okay.
a teen or a small adult, or small adult, small adult, a young adult, they're more likely to have family bring them in because they're
Yeah.
like, whoa, my kid won't leave their room.
Yeah.
This isn't okay. Somebody
Yeah.
needs to see them. And I want to be very clear, these people are not inherently dangerous. That's not a thing.
Right.
They're
No.
just wired different. And actually, I'm going to get to a question in a little bit about some distinctions between this and autism
Yeah.
spectrum disorder. Because
Yeah.
again, if your kid's in his room reading a math book and he's not upset,
Yeah.
It's possible that they just have a little bit of a quirkier personality. It doesn't make them inherently dangerous,
Right.
right? But our society rewards extroversion and being just typical, neurotypical,
Yeah.
extroverted, does well in a typical academic setting. That's what our society prefers. And so when people don't show up that way, they get put into all kinds of categories.
Yep.
So now let's talk about schizotypal. So, schizotypal personality disorder may include severe anxiety, paranoia, disorganized thinking, odd beliefs, derealization, and psychosis.
Mm-hmm.
So, the mental health symptoms themselves are a little bit more intense with schizotypal.
Yes.
There's a lot of overlap between the signs and symptoms between schizoid and schizotypal
Mm-hmm.
because both conditions limit a person's ability to form relationships. Schizotypal, though, has a couple of extra features.
Okay.
Believing that others are talking about them. So there's a little bit more of an aspect of paranoia,
Okay.
magical thinking, unusual body sensations,
Mm-hmm.
suspiciousness or paranoia. They might have a peculiar appearance. They
Mm-hmm.
might have confusing or eccentric thinking, speaking, or behavior patterns, and very high levels of social anxiety.
Mm-hmm.
So if you took someone with schizoid personality disorder and you put them in a big sea of people,
Mm-hmm.
they're probably just going to do their own thing.
Right.
They're
Exactly.
going to be in their head, or they're going to be reading a book or listening on their AirPods or whatever. They're
Right.
not going to be anxious. You put a person with schizotypal in that same situation, they're going to have much higher anxiety.
Yeah. It's going to look a lot different.
Schizotypal can involve periods of psychosis where they see, hear, or feel things that are not present. And they are more likely to have, like we said, social anxiety, just general anxiety and depression.
Yeah.
There are way more schizotypal people than there are schizoid personality disorder.
Mm.
It is up to 3 to 4% of the population. That's a lot.
Wow.
That is a lot.
That is a lot.
So this is way more common than I think people realize.
Mm.
Men are more likely to develop this disorder, and they believe part of that is the cultural norms that steer males away from expressing emotions. Men are more likely to kind of go take this little off ramp
Yeah. Because they don't share emotions.
because they don't share emotions.
That's fascinating.
Hmm. So, one of the key differences between schizoid and schizotypal,
Uh-huh.
somebody with schizoid usually doesn't care about the condition and they don't really want to improve anything because they're fine.
Right.
They're a happy hypoxic, they're a happy schizoid. They are happy with the way that their life is. Maybe other people are stressed out about it, but they're okay. They're not
Yeah.
having anxiety and depression about it.
Yeah.
Somebody with schizotypal personality realizes they're different and they're uncomfortable with the fact that they're different. And they will seek treatment for the depression and the anxiety.
Mm. Would you say that the from your story time that that guy was more schizotypal?
Yes.
Yeah, that's what I thought.
And actually, I think he had schizotypal and full blown schizophrenia, both, which you can
Mm.
have. And we'll talk about that in a minute.
It's like the double whammy for him.
Double whammy for him.
Oh,
And still to this day, just somebody that I think about and wonder how they're doing because I just genuinely am so happy I got to know them.
yeah.
Very special person with an interesting thought life. These folks are interesting. Like, there's really nothing to be afraid of. You need
Hmm.
to pay attention to certain things. And there are some things we're going to talk about in terms of what not to do. But these are
Hmm.
not scary people. Just think of them as really interesting people who have just a different thought life than
Right.
maybe you or I have.
Right.
Okay, so one of the things that is kind of interesting about somebody who has schizotypal
Hmm.
is they tend to be more outwardly odd or eccentric. So these folks will many times stand out in a crowd because of how they show up. So we've had folks come into treatment and they're wearing something really interesting. And there's already kind of like a whoa, something is happening here.
Mm-hmm.
I really enjoy these folks I do.
Okay.
I think they're so interesting. I want to know everything about their inner world,
Yes.
right? But it is different. Something different is going on in their brains.
Yeah.
Okay.
I just want to make sure I'm clear. So schizoid
Yes.
personality disorder, they don't have as many or as loud like delusions or hallucinations.
Yes.
That's not as loud for them. It's more of how they think.
Yes.
Okay.
Yep. It's more how they think, and they really are just alone more.
Yeah.
And
Okay.
they just get pleasure more from studying or learning about things than they
Yep.
do being with people.
Because I think one of the things that I want to make sure our listeners are mindful of is that just because they have a schizo something doesn't necessarily mean that they have all the same symptoms.
That's right. And it doesn't mean they have psychosis even,
Right.
right?
Yep.
So when we talk about treatment, okay, with somebody with schizoid personality, talk therapy
Mm.
is something that you can do. Okay.
They enjoy it though.
No,
Right. Okay.
they do not enjoy it.
Yeah.
However, if they were to come in, what you would maybe try to do is come alongside them, listen to their thoughts, start to point out some things that are maybe different, and maybe the benefit of close relationships. Like maybe we try to highlight, hey, it's good to have a couple people in your corner,
Mm-hmm.
right?
Yes.
They do have medications sometimes for folks with schizoid, but it's typically treating if they have a co-occurring mental health disorder like anxiety or depression,
Right.
right? If they have that, which again, they're a little bit less likely to have that. For
Yeah.
schizotypal, what the research supports is cognitive behavioral therapy
Mm-hmm.
to shift problematic behaviors and change distorted thinking that keeps them from connecting to people.
Mm-hmm.
Family therapy is great for folks with schizotypal to build that bond with people
Yep.
in the family. So that's actually really good.
Okay.
And then there's more medication options for someone with schizotypal because we have medications that can treat psychotic symptoms.
Mm-hmm.
We have mood stabilizers, antipsychotics, and then also we have antidepressants, anti-anxiety medications. So medically, we can help these folks. That's something
Yeah.
that's really encouraging.
Yeah.
Question for you, Nat. Do you think these folks get involved in domestic violence? And if so, what might it look like?
I mean, I think anyone's capable of getting involved in domestic violence. I think schizoid, I don't think they would be super aware that they are involved or getting involved in a domestic violence dynamic. I don't think their goal is power and control necessarily. I think it would be, which most of the guys we work with would fall under what I'm about to say. I think it would be more out of fear.
Mm-hmm.
The intention wouldn't be to control somebody. Does that make
Right.
sense?
Mm-hmm.
Yeah, but I think anyone's capable. I just don't think, I think individuals with schizoid or schizotypal personality disorder don't necessarily know that
Right.
they are being abusive.
Right. They may not know they're being abusive, or they could potentially get into an abusive relationship. So
And
they could be with someone who
yeah,
takes advantage of them,
yeah.
like maybe they're getting social security income or
Yeah.
whatever, or maybe they're homeless and they're living on the streets and they pair up with somebody else on the streets, and they can sometimes end up in really difficult relationships because they don't really know how to do relationships,
Yeah.
and they can be taken advantage of sometimes in those ways.
Yeah.
Yep.
Mm,
So the encouraging thing is there is treatment for both of them, and we run into that sometimes. I don't think we run into this a ton with our population, but we do sometimes run into it.
yeah.
Substance abuse community, far more.
Mm-hmm.
I ran into far more of this in my substance abuse community, and what's tricky there is it the methamphetamine or is it schizotypal, and it's really hard to know
Right.
what is happening.
Well, and I'm sure we'll get into this, and you can develop some sort of schizoid something diagnosis from the use of drugs.
Absolutely.
So
And
again,
folks particularly who are abusing methamphetamine,
Mm.
they get real quirky sometimes. They have interesting ways that they spend their time.
Yeah.
They can start dressing in unique and interesting ways. And so that's where differential diagnosis is so important to
Hmm.
determine what's actually going on. Because if
Yeah.
somebody is abusing methamphetamine and we try to put them on some antipsychotics and mood stabilizers,
Not
we've
going to
got
go
a whole
well.
bunch of stuff happening in their brain, right?
Yep. That wasn't happening before.
Exactly.
So it's important to actually find out in this scenario which one came first, the chicken or the egg.
Exactly.
Yep.
That's right. So now we're going to transition into paranoid personality disorder.
Okay.
This one we see a lot in our
Yep.
population. And,
Yep.
and we are really dealing with this the last couple of years in particular. I think we've seen quite a bit of this.
Yep.
Okay. Paranoid personality disorder is the fourth most common personality disorder in the US.
Wow.
So there's quite a few folks who have this.
Yeah.
They tend to believe other people intend to harm them or take advantage of them. That's kind of the fundamental piece of paranoid personality disorder.
Yeah.
They are more likely to develop substance use disorders,
Hmm.
and those impact their ability to trust other people.
Yeah.
But they also tend to not trust family members and friends who are trying to help, and they have a really hard time developing a stable support network.
Yeah.
While these folks may not want to go to treatment, they can benefit from targeted interventions that challenge cognitive distortions and help them establish more trust with professionals and peers.
Mm. Okay.
Here's the symptoms of paranoid personality disorder. And I want you guys to really think about these because odds are someone in your life may actually have this.
Yes.
And you may write them off as arrogant or annoying or whatever, but they may actually have like a fundamental problem with their thought process.
Yeah.
Most paranoid personality disorder symptoms reflect a mistrust in the world and other people.
Mm.
So when we talk about targeting cognitive distortions in treatment, this personality disorder is one big cognitive distortion.
Yeah.
Everything kind of goes through that lens.
Yeah.
And there's a range of severity. So here's some of the behaviors that you might see. They might be tense.
Mm.
They may have a really hard time admitting being at fault or being wrong. They may be kind of cold and emotionless.
Mm.
They may withdraw and isolate, right? Because if people are out to get them, they don't want to be around people.
Mm-hmm.
They may engage in excessive tracking, recording, or policing behavior. This
Mm-hmm.
one's so interesting because this is where we get the stalking. This is
Yes.
typically how these folks end up in our office, is this kind of monitoring that they do.
Yep. Yep.
Exhibiting a short temper and overreacting to minor or perceived slights,
Mm.
and confronting people in person or over the phone with accusations of betrayal.
Mm.
That's another way they show up. Well, they must be cheating on me. They're cheating on me. They're cheating on me. They're cheating on me. And there's like no evidence to support that.
Mm.
Well, yeah, that fixation is overrepresented in the domestic violence population. But what if it's also a symptom of paranoid personality disorder?
Right.
Wouldn't that make sense then?
Yes.
They may not be stalking because it's because of the power and control element. They
Mm.
may be stalking because they genuinely don't believe that their partner can be or is faithful.
Mm.
Isn't that interesting?
So interesting.
This one I've had to do a lot of research on lately because it's been popping up a fair bit.
Well, and it would be hard for like you and I or anyone on our team
Mm-hmm.
if someone says that they're diagnosed with this and we don't have like evidence of that
Yeah.
because, like that looks, I mean, I know that there's a difference between the diagnosis piece of it and then
Yeah.
also like just regular power and control stalking.
Well, and how do you know?
Right, exactly.
And for me and you, man, we're gonna go in. We're gonna go in
Yes.
on the stalking because it is insane behavior.
So dangerous.
It's so dangerous and it really hurts victims. It
Yes.
just takes their whole sense of security away.
Yes.
But if we look at someone with paranoid personality disorder and we say, hey, you're really scaring her by following her, they don't care because
Mm-mm.
they believe this thing is happening and their brain is compelling them to check on it.
Mm-hmm.
And so the intervention looks a little different than like a tough love, hey man, you don't get to know where she is. And it may look a little more like, hey, how long have you had these kind of thoughts? Have you
Yeah.
believed this about every partner you've ever had?
Yep. Like has this come before?
Right,
Yep.
exactly. One of the ways that we diagnose this, which is really, really tricky, is we have to tease it out from these other disorders,
Mm-hmm.
right? And it can be a little tricky because there's a fair bit of overlap in each of these clusters. There's a fair bit of overlap, right? Here's some examples of behavior because it's kind of a wide range. One person might isolate in their house and look through the blinds at people walking around the neighborhood because they just think something's happening maybe in the neighborhood or maybe with that person. Another person might map out an elaborate conspiracy theory using newspaper clippings and posting everything to the wall,
Right.
right? But most of the folks with this disorder actually quietly suffer
Mm-hmm.
and only signal their paranoia to others with subtle signs. So you may only see this in how they glance at each other or in their speech. They might say something that sort of gives a hint that maybe they're paranoid, some sense that other people won't believe them.
Yeah.
And so they work really hard to keep their suspicions hidden. And we've talked about the impact of family being like, dude, you can't talk about that stuff. And so sometimes we see clients who are like, they just stare at us like they're ready to burst, but they don't want to say anything because mom and dad said, don't tell people this stuff. It's crazy. Right. And so they don't tell the person who can help. Okay. So when we talk about causes, we talked a little bit about how schizotypal and schizoid can have various causes, including some environmental factors, but also genetic factors. And there can be overlap with schizophrenia proper.
Mm-hmm.
Some of the potential causes of paranoid personality disorder are there's basically three categories of causes. So there's genetic,
Okay.
biological, which means there's a brain difference that happens organically somehow, or environmental.
Okay.
So paranoid personality disorder is closely linked to a family history of cluster A personality disorders, schizophrenia, or other psychotic disorders.
Okay.
What that means is if somebody has a family history of those things, they're more likely to have paranoid personality disorder.
Mm.
And I know every time we do an eval, we ask family history because that's one of the things that's really helpful for
Yep.
us if we're doing a rule in, rule out kind of thing.
Yep.
There is also a strong connection between paranoid personality disorder and childhood abuse.
Mm.
So when we have childhood trauma and maybe our family dynamics were kind of emotionally distant,
Mm-hmm.
we won't have as much affection. And so sometimes when that happens, or especially when there's violence between parents, kids don't feel safe, they retreat into themselves. They can kind of develop these traits sort of as a product of protecting themselves as well from
Okay.
an environment that was actually scary.
Mm-hmm.
Okay. So how we diagnose it is you have to look at it as a pervasive distress and suspiciousness, which means it happens in different contexts
Mm.
and that they believe that the other person's motive is malevolent. So what that means is they believe people are out to get them.
Yep. We've had less than a handful of these show up like in the last couple years, but it is there now that you're saying that, there is such a difference from someone who just has stalking behaviors versus this diagnosis.
Having it be this pervasive, right?
Yeah.
So technically, you have to have 4 of the 7 of these traits. And I want you to think as I'm reading these how this shows up in the land of domestic violence,
Okay.
because this one really does. Being reluctant to confide in others due to fear of betrayal, fixating on doubts about others' loyalty or trustworthiness,
Mm-hmm.
repeatedly accusing a partner of sexual or romantic infidelity, holding on to grudges and refusing to forgive even minor insults or slights,
Mm.
perceiving demeaning or threatening meanings in neutral statements or events, which we see that one a lot in DV,
Yeah.
suspecting without evidence that others are exploiting, harming, or deceiving them, inaccurately perceiving hostility in others, and making quick, aggressive counter reactions.
Mm.
And then with this, if you were going to diagnose this, you would have to look at the other disorders that are near this in terms of what the symptomology is and make sure it's more this than something else. So you'd
Mhm.
be looking at kind of the better fit. People rarely come to treatment for paranoid personality disorder because they don't think a therapist can solve the fact that other people aren't trustworthy. They don't
Mm.
understand that they're a factor in any of
Right.
this, right? So
Right.
it's like, I'm not going to go to a therapist. How's that going to help my sister who's out to get me?
Right.
Right? So they don't always have that level of self-awareness.
Yeah.
Typically, they come in because they have a related condition, something
Yeah.
else is going on. Or in our case, domestic violence, we can have folks pop up who have some of these traits.
Mm.
The age of onset is usually late teens or early adulthood. And it talked about kind of who's at risk.
Mm.
But really, when you look at it, it would be people who maybe had a difficult family history, maybe a family history with some other associated psychotic or cluster A personality disorders.
Mm.
Also, frequent victimization can reinforce a worldview that people in positions of authority can't be trusted. So
Mm.
this is one that can really grow out of trauma.
Mhm.
So 4.5% of the population in the US, which is more than 14 million people,
Mm.
have this. Think
Wow.
about that. I mean, this is a lot of people. This is more than narcissism. This is more than antisocial, right? The prevalence of paranoid personality disorder is anywhere from 2 to 10% in an outpatient mental health treatment
Mhm.
facility.
Wow.
In psychiatric inpatient unit, it's 10 to 30%.
Okay.
And then a recent study shows that about 10% of people receiving treatment for alcohol use disorder have co-occurring paranoid personality disorder.
Wow.
So, Nat, if we have somebody with paranoid personality disorder who has a domestic violence offense, and the DVRNA has a whole section about have they been unfaithful? Do you have
Mhm.
proof? Are you
Yep.
persistently, obsessively jealous? Right?
Are you checking their stuff? Yep.
So, how do you think we can, as clinicians, and also if people have folks like this in their life, like what do you even do? What do you do?
Mm.
How do you identify this? And then does it even matter whether
What do
they're jealous because of just DV or because they have
oh.
this disorder?
Oh, it for sure matters.
Yeah.
I think, I mean, it kind of goes back to what we said earlier. Individuals who have this disorder, it's not just showing up in their intimate relationships. It's most likely showing up in a lot of other relationships and historically has shown up in other relationships,
Yeah.
just this massive level of distrust.
Yes. Shows up at
And
work, all that
yes,
kind of stuff.
if someone is not diagnosed with this and does not have this, whether diagnosed or not, that looks very different because it doesn't show up in other relationships of theirs. It only shows up in their intimate partner relationships.
Yep. Yeah, absolutely. Okay, so to wrap up tonight, we are going to talk about schizophrenia, and this is the direct straight line to the Slender Man episode because
Perfect.
those gals had schizophrenia. So, age of onset, there is a narrow range of onset compared to other disorders.
Mm-hmm.
For men, the symptoms of schizophrenia usually begin in a small window of time
Okay.
between their late teenage years and their early 20s.
Okay.
Women typically have those symptoms emerge slightly later
Hmm.
between their late 20s and their early 30s.
Mm-hmm.
Someone showing signs and symptoms of schizophrenia for the first time before age 12 or after age 40 is rare. Now,
Okay.
remember, the little girls in schizophrenia were 12, or in
Yep.
schizophrenia, in Slender Man. The girls
Yeah.
in Slender Man were 12.
Yep.
So the fact that they had that childhood onset is very rare.
Mm.
The symptoms can occur at any time, but the average age of onset for schizophrenia is the late teens and early 30s for men and for women, respectively.
Mm.
It's about 1% of the general population. And in the early course, so there's a course of illness to schizophrenia. So what that means is just like with cancer and other disorders, usually it looks a certain way in the beginning, and by the end, it looks a little different.
Yeah.
Early on, people typically isolate, they
Mm.
become suspicious, and they display increasingly bizarre thinking.
Mm-hmm.
Each person's experience with schizophrenia will have some common themes with other folks who have the same condition, but then so many of the aspects of it and its path are unique because everyone with schizophrenia has their own presentation of it.
Yeah.
So there's three main categories of symptoms. Number one, positive symptoms, which means the presence of something. Number
Okay.
two is negative symptoms, meaning the absence of something.
Got it.
And number three are just straight up cognitive symptoms. Okay.
Mm-hmm.
Positive symptoms are the introduction of psychotic symptoms, which represents a break from reality.
Okay.
These would be hallucinations, which people think hallucinations are just visual.
Right.
That's not true. Hallucinations are any sensory error
Mm.
where a person is hearing, seeing, smelling, tasting, or feeling things that are not present. That's a
Yep.
hallucination.
Yep.
A delusion is a strong belief about people or things that are unrealistic or not supported by facts.
Mm-hmm.
Thought problems, which is different than a delusion, is when a person's thoughts are really disorganized. They'll
Mm.
stop a train of thought, make up a new word,
Mm-hmm.
switch gears on you real quick.
Yeah.
And sometimes there's movement issues too. But what
Mm.
that means is sometimes these folks are moving a lot, and sometimes they will sit and not move at all for a long period of time.
Mm-hmm.
Does that make sense?
Yep.
Positive symptoms, it's weird to call it a positive symptoms, but it just means it's a presence of something.
Yep.
Negative symptoms are losing feelings and interests that somebody previously had.
Okay.
Flat affect or emotions, less pleasure and happiness in their life, problems completing behaviors, and speaking less often. And then the cognitive symptoms are diminished ability to think, understand issues, and make choices, forgetfulness, decreased ability to focus and pay attention, forgetfulness, that kind of stuff.
Yeah.
So when symptoms start, this person may change their friends, start underperforming at work.
Mm.
School can change, if you've got a kiddo kind of at the end of their high school years or in college, and all of a sudden there's a big shift.
Yeah.
You'll see a big change in sleep patterns.
Mm.
And a lot of times loved ones think, oh my gosh, they're depressed.
Mm.
They're depressed. Or they think maybe it's a breakup, maybe something's going on. And sometimes, particularly with young adults, parents are trying to back off a little bit.
Yeah.
And there's a lot of transition that happens when people go to college. So this gets missed quite a bit.
Okay.
So there's a lot of co-occurring mental health and physical health issues linked to schizophrenia. So many of them also have a co-occurring anxiety disorder. So 23% have OCD.
I'm not surprised.
15% have panic disorder.
Mm.
29% have PTSD. 30 to 54% have depression.
Mm.
Many of them use substances. It's up to about 50%.
Yeah.
And they typically smoke cigarettes too.
Mm.
And all of these things are an effort to calm the brain down, slow the
Yeah.
brain down, calm the brain down, right?
Which makes sense.
A person with schizophrenia can have symptoms of paranoid personality disorder, schizotypal. There's a separate condition called schizoaffective. There's
Hmm.
all the schizo things, right? Schizoaffective that blends aspects of
Uh-huh.
schizophrenia with mood disorders,
Mm-hmm.
common in depression and bipolar. So schizoaffective is kind of like if bipolar and schizophrenia had a baby.
Yeah.
With depression, I don't know.
Yeah.
It looks a little bit like that. And then the other thing is they have a high risk lifestyle. So then they have physical conditions as well. And those can be obesity, diabetes, heart problems, breathing issues. That can all go with that. And then also the medications sometimes that folks are on for schizophrenia can
Mm.
exacerbate some of those symptoms as well.
Mm.
A tough one.
That is a tough one.
High risk of suicide. So first of all, they have a shorter life expectancy
Yeah, I'm not
because of
surprised.
the physical health concerns and all of that stuff.
Yeah.
But people with schizophrenia are far more likely than the average person to think about suicide, attempt suicide, and complete suicide.
Yeah.
So 5 to 6% of people with schizophrenia die by suicide.
Mm. That's sad.
That is so high,
Yeah.
that number. That's 5 or 6 out of 100. Isn't
Hmm.
that just terrible?
That's so sad.
And 20% of folks with schizophrenia will attempt at least once.
Mm.
And then obviously the rates of people who are thinking about it is even higher.
Right.
Young males have the highest risk of suicide from schizophrenia and in general,
Yeah.
highest risk of suicide, especially if they're also abusing alcohol and other drugs.
Yeah.
The risk factors for suicide with schizophrenia are high depression,
Mm.
not following treatment recommendations, which includes medication, feeling hopeless, not having a job, and being recently released from the hospital.
Mm.
People who take their medications as prescribed have a lower risk of suicide. So if they have family coming around and supporting them, they're less likely to attempt or complete suicide.
Yeah.
What do you think here in those stats, Nat?
I mean, I'm not super surprised. You
Mm-mm.
know, it actually makes me think of there was this individual who used to live in Summit County. I don't know where they are now.
Mm.
And they were schizophrenic for sure. And super nice guy though, like you'd see him around homeless. He would go into like the local restaurants and they would give him a free meal.
Mm-hmm.
People really tried to take care of him. But I remember, I never really had a conversation with him just because I only would see him like walking along the side of the street when I was driving. I never saw him in a restaurant actually.
Yeah,
I just knew that when he would go in, the county would really take care of him. But yeah, I just remember thinking like, you know, he's so lost in his own brain and you'd see him talking to himself and waving his hands. What we see is nothing, but for him, there's something there.
yeah,
Uh, And so, yeah, I'm not surprised by the statistics because I'm sure, in maybe the limited times that they come to where they like realize, or someone's like, who are you talking to? They're like, they feel crazy,
absolutely.
you know?
Well, and we have to talk about marijuana for a second.
Oh
So
my
in
gosh.
Colorado, okay, Colorado's weed central, right?
Mhm.
Everywhere is weed central now, but Colorado, we are in there. And Nat and I, we don't have a bunch of attitude about marijuana. It is what it is. People use whatever they're going to use, however they're going to use it, whatever. Now, when it comes to schizophrenia, high potency THC, which is
Mhm.
what we have here, you
Yep.
literally cannot get low potency THC very easily. It's
No.
high stuff. If you mix that with a vulnerable brain, it can actually trigger the onset of schizophrenia.
Yep.
That is a known thing. It's in the literature. Don't come for us. We have no issue with weed. Whatever, have your gummies. You just need to understand your
Yep.
brain and understand that, first of all, younger brains are more susceptible to the effects of cannabis longer. It has a bigger impact. But
Yep.
also, if you have like a family history of this stuff, or you're at an increased risk for this, and you introduce high potency THC and specifically over a long period of time,
Mhm.
it can actually trigger the onset of schizophrenia.
Yes, especially in 20-something-year-old men.
Exactly. So you got to know this. And,
Mm.
if you don't agree, that's fine. But I'm trying to tell you.
Well, here's the thing. I This is not going to be a popular opinion, but
Hmm.
I initially, when I was younger and marijuana was deemed legal, not just medical marijuana, but in general,
Yeah.
at first I was like, well, this is going to be a shit show. But then I
Right.
was actually really glad that it was because we can do more research on it now. And there
Right.
has been a ton more research on it
Yeah,
showing these things.
absolutely.
We actually didn't know this before. And also, marijuana back in the day wasn't as insane as it is now, like you said.
Exactly.
But it still shows that marijuana use, regardless if it's flower or freaking man-made,
Exactly.
it's going to increase your anxiety over time, regardless of what you use.
Also true. And
So,
build a bit of a dependence just like everything else, and you can have withdrawal effects just like everything else. So
yes.
you just need to know that we're not anti-weed. We just want you to be
No.
informed, right?
Yes. Yep.
So when it comes to schizophrenia and crime, I want to say this very clearly because Nat and I work with people who've committed violent crimes, right?
Hmm.
Having schizophrenia doesn't mean you're more violent than anyone else. The vast majority of people with schizophrenia are not violent and never commit crimes.
Hmm.
They are more likely to hurt themselves than anyone else.
Yep.
That being said, if someone has schizophrenia and they're abusing substances,
Hmm.
it can spark feelings of anger. And the highest risk is when somebody is in a period of untreated psychosis.
Hmm.
Someone with intense hallucinations or delusions may experience confusion and aggression. They're scared, partially,
Hmm.
right? We got to understand that.
Hmm.
Now, when in treatment, those risks go down, and when they're compliant with their medications, those risks go down, and everything else.
Yep.
As many as 20% of people in jail have significant mental health issues,
Yep.
right? So, one of the things that's interesting is when my client, in the very beginning of the episode, when I talked about the client who observed this before I did,
Hmm.
folks who have spent time in these institutions often have an amazing radar for mental health issues, and they also know how to interact with them better than we do sometimes.
Yep.
You know, one of the things I can tell you is do not approach someone who is talking to themselves like on the street. You
Correct.
may want to be really kind and give them food or whatever. That's all great. You
Yep.
will see me moving away. And the
Yep.
reason is because
Yep.
I don't want to become involved in the delusion or in the hallucination or delusion that they're having.
Yep.
So my family kind of laughs at me, but I have a little bit of a hair trigger when it comes to this, and I start moving away just because I know that I can end up becoming a part of the
The
hallucination
delusion. Yes.
and the delusion, right?
Hmm.
Treatment, there's a lot of different ways to treat this. Schizophrenia is treatable and manageable, right?
Yep.
It is going to be difficult. 20% of folks with schizophrenia can find effective treatment and actually manage their symptoms and function well in
Hmm.
society.
Yep.
80% remain chronically ill and require support for daily living.
Yep.
So if you know of a family that has someone in their family struggles with schizophrenia,
Mhm.
one of the best ways you can support them is just to recognize they have a chronically ill family member.
Yeah.
And so there's different things you could do to help that family in supporting that person.
Yep.
So when we talk about Slender Man, Nat, after learning all of this,
Hmm.
what does it tell you about that crime in particular? Like, what stands out to you when you think about those girls having schizophrenia?
Well, they're not the norm.
It's a literal statistical anomaly. Like, it
Yeah.
is so freaking unlikely that two childhood onset schizophrenic your girls
Yep.
would find each other in a small town
Yep.
and then react violently, which is also the minority,
Yep. Well,
right?
here's the thing. I don't think all of them had schizophrenia or the two.
I know we both think
I think only one of them did, and then the other one just followed suit.
I think so. I mean, they both had pretty extensive testing, and you can't fake like the MMPI.
Right.
You'll get a fake bad, but I'm with you. It feels so unlikely that they both had clinical schizophrenia. And how do you separate Anissa's experience from what she might have been mirroring
Right.
from her time spent with her friend?
Right. How do you make that different?
Well, I mean, if I'm the evaluator and
Yeah.
Anissa walks in, Anissa's been spending all of her time with someone with a very severe case of
Yes.
childhood onset schizophrenia. So in theory, Anissa could shadow, mirror,
Oh
reflect
yeah.
all of
Well,
those behaviors.
that's what I think
Yeah,
she was doing.
I think so too.
If I'm being honest, I think she was mimicking. I
Hmm.
think she picked up on the fact that her friend had a diagnosis and
Hmm.
then saw that her friend was potentially going to get less time than her and was like, "Oh hell, I'm hanging my hat on the same thing she's going through."
When those attorneys are like, now right? Maybe tell them about this, right?
Yep. Yep. Did you
Yeah.
also hear voice, right? Like they probably fed it to her.
You know what else? As I'm sitting here, I'm thinking about the assessment tools that we use and what they use for adolescents. They probably don't have a ton of
Mhm.
adolescent geared schizophrenia assessments
Mhm.
because it's so rare
Mhm.
in women in particular, in females.
Yep. And kids.
Yes, that's interesting. I didn't
Yeah.
even think about that.
Yeah.
So here's my last question, Nat. What do
Okay.
you do if you have a loved one that has or may have had one of these conditions?
Gosh, do the best that you can to support them
Hmm.
when they're in their delusion. I mean, this is what we do as therapists. You have to go with the delusion. Try not to
Yeah.
talk them out of it.
Yeah. Don't
Um,
directly challenge it.
don't directly challenge it. And, you know, I could be wrong about this, but I think some of their symptoms get worse when other people's anxiety is bad.
Mm-hmm.
And so my encouragement would be to try to stay calm.
Yeah.
You can try to stay calm. And again, don't try to argue with them.
Yeah.
It might be able to calm their nervous system down as
Yeah.
well, but just do the best you can. Try to get them help. I know it's not always the easiest thing to try to get someone who's struggling with paranoia or delusions or hallucinations
Yes.
help. But you know, s- sometimes maybe when they're a little bit less in those states,
Mm-hmm.
try to utilize that time for their benefit, you know?
And Nat, we neither of us specialize in major mental illness, right? That's not our
Hmm.
clinical specialty. However, we work with folks who have these diagnoses, certainly court involved, right?
Yep.
And I'm just struck every time by how much it does for them when you just establish a little bit of safety.
Yeah.
We have a few folks, even now and in the last few years, who've had an issue like this. And
Mm.
even just listening and being like, that sounds really scary. And they'll say, yeah,
Yes.
I'm scared. And you can say, I'm so sorry you're scared. I'm
Yeah.
here with you. I'm here. I'm sitting with you and it's going to be okay. And, they're people. They're still people. They're not aliens. They're just people. And so I think if we can sit there and have empathy for the fear that they feel, because a lot of them feel a lot of fear,
Hmm.
that has helped me build relationships with some of these folks
Hmm.
where we can get them some help. And you know what? We have been able to support people in taking their medications
Yeah.
because they know we care about them.
Yeah.
That's actually the only time I've been able to get somebody to
Yeah.
follow their regimen is when they believe I care. They won't do it just because we tell them to,
Right.
right?
Yeah.
I hope this is helpful. I know that the Slender Man episode brought up a whole bunch of questions about this stuff, so I hope it's helpful. And we will talk about the other cluster in the next couple weeks, maybe next week, maybe a couple weeks. We're still figuring that out.
Yep.
But thanks for joining us. And as always,
Bye, forensic friends.
bye, forensic friends. I'm Janine.
And I'm Nat.
And as always, thanks for listening and join us next week for more crime, psychology, and heart.